Thinking Aloud. Conversations on the leading edge of knowledge and discovery with psychologist Jeffrey Mishlove.
Hello and welcome. I'm Jeffrey Mishlove. Today our topic is coping with trauma. My guest is Professor Stanley Krippner, who is Alan Watts Professor of Psychology at Saybrook University. He is the author of Haunted by Combat and also Ptsd, Biography of a Disease. So he's a specialist in trauma. In addition to many other specialties, he is a past president of several psychological associations. He has received lifetime career awards from more than one psychological association. He is the author of over 1,000 academic papers. Welcome, Stan.
Thank you.
When we talk about trauma and PTSD, we're dealing with a syndrome which is essentially caused by the environment rather than a genetic, an internal or neurological problem, at least initially.
Absolutely. For those listeners who don't know the term, PTSD is post-traumatic stress disorder. Mm-hmm. And this is on a spectrum. There are many responses to trauma. The trauma is a blow to the system. It's a blow to the body or the mind or the spirit or the emotions or all four. And when the blow is something that produces a whole range of symptoms that last for several months or more, then it qualifies as being a post-traumatic stress disorder. Now, there can be post-traumatic stress, which is temporary, and there can simply be post-traumatic recovery. So you never know what people are going to succumb to the extent that it becomes necessary to treat them or give them therapy of one sort or another.
Mm-hmm. Well, and of course, it's very commonly associated with warriors who are sent into dangerous combat zones.
Yes, absolutely. And if you go back in history and even prehistory, myths and legends, you find out that this has been reported for millennia, that people go into battle and their best friend is killed, or a baby is killed accidentally, or a wife is raped, and they don't recover from it. They have what we would call today symptoms. And you find this in different parts of the world, of course. Philosophically, I think that this argues that the human system is basically benevolent, that people are connected by love, compassion, and cooperation. This idea, by the way, originated with Darwin, who stressed cooperation, much more than survival of the fittest. That was never a term that he liked. And so to disrupt this bond of collaboration and compassion, yes, is traumatic. It does rip apart the system to some extent. Many people recover. They pull things back together, and many people, sad to say, never recover. Yeah. I became interested in trauma during the Second World War because my second cousin, Marcia Gates, was in the Philippines when the Empire invaded and took over the Philippines, and she ended up in a prison for 4 years. Mm-hmm. She was very lively and effervescent and cheerful before the war, and she came back damaged. She came back sober, serious, yearning for what she called my bluebird of happiness, which she never found, either through marriage or through continued work as a nurse. Died too young, and I miss her to this day, and much of my work on trauma is more or less in her honor, because I could see the change even at a young age. One of the things that triggered my interest in psychology was to see close friends and relatives become engaged in not only trauma, but other types of mental disorders and mental injuries. So fast forward to the Vietnam War, which I was adamantly opposed to, as in the first anti-war march in New York City, but never got to the point of spitting at the returning soldiers. I felt compassion for them, in fact, and I was an advisor to two different groups of veterans who were trying to pull their lives together coming back from Vietnam, and that's when I became aware of the fact that many of them were severely traumatized. PTSD is a fairly recent term. In other wars, it's been called soldier's heart, shell shock, war neurosis, etc. But
combat fatigue.
Combat fatigue, thank you.
Yeah.
And so now the accepted term is post-traumatic stress disorder. Well, I actually was invited to a health conference in the former Soviet Union, and I decided to speak on my experience with Vietnam veterans and PTSD. It created such a sensation that I was called to confer with the top psychiatrist who was treating Afghanistan veterans. And so I told him what little I knew about PTSD and therapy. And so that led to a interesting development. Back in the United States, I was asked to write about a book on diseases of the 21st century. And I said, well, I look at the list. You don't have post-traumatic stress disorder. Oh, yes, we want you to write about it. I said, well, I'm not a clinician. I'm not a psychotherapist. I need to get one of my students who was a Vietnam veteran to co-author it. Yes, they said fine. So we wrote the chapter. They liked the chapter so much, they said, why don't you and Dr. Paulson write a book? So we came out with our book, Haunted by Combat, and it was given a favorable review by the New England Journal of Medicine, of all places. Nothing I've ever written has been reviewed by that particular journal. And then that led to a bid by another publisher to do the first book in their series, Biographies of a Disease. And this I wrote with two other graduate students who had Ph.D.s, who were psychotherapists. And that got the best review from the American Psychological Association than any book I've ever written. Now, this is very uncanny because I've interviewed veterans with PTSD, but I'm not a psychotherapist. I don't do therapy. But I think that I have discovered the way that people should talk to people with PTSD, not only veterans, but survivors. I don't use the word victim. I use the word survivors. Survivors of automobile accidents, tsunamis, rape, bullying, abuse, etc. People who have been traumatized. And you never say, oh, yes, I understand what you've been through. No, you don't understand what you've been through until you've been there yourself.
Well, just to back up a second, Stan, I know you're not a psychotherapist, but you have facilitated many groups along the way. As a matter of fact, as I recall, you facilitated groups of people undergoing sex change operations long ago. So you do have a lot of experience working with people.
Yes, I'm a good group facilitator, and you have to know about psychotherapy to be a good group facilitator, but you don't have to be a psychotherapist.
Right.
Yes.
Right. And one of the intriguing things when I interviewed Dr. Charles Whitfield, who is a psychotherapist and specializes in people who have experienced trauma, he made a point of saying he doesn't consider PTSD to be a mental illness per se. He considers it to be a healthy response to a traumatic situation.
He's absolutely right. PTSD is the best response a person can give to a disordered situation. The disorder is in the situation, not in the person. The person is doing the best that he or she can, given the trauma involved. So I'm very sympathetic with that point of view.
So in Whitfield's case, he said, it's better not to prescribe psychotic drugs for this situation. People can get misdiagnosed as being schizophrenic or paranoid. He felt that they need to process. They need to work through these difficult, painful emotions, and that's best done through a variety of humanistic and spiritual approaches, talk therapies, essentially.
Yes. Mm-hmm. Well, again, I sympathize with him. A lot of people with PTSD, especially veterans, are being over-medicated, in my opinion. This is palliative. It's superficial. Sometimes it's necessary simply to keep them together before they have intensive psychotherapy.
Mm-hmm.
But no, I do not suggest it long-term. I'm very opposed to people with PTSD taking medication for the rest of their lives, because the medication has side effects which can be just as bad as the PTSD. There are some very, very good therapies out there. There are new therapies coming up all the time, like MDMA or ecstasy therapy, virtual reality therapy, very novel, very effective therapies, in addition to various types of cognitive behavioral therapies, different types of therapies where people are exposed to the trauma in their imagination and work it through.
Desensitization.
Yes, desensitization of one sort or another. The important thing to realize, and any specialist in PTSD will agree with me, no two cases are the same. Each person demands a tailor-made type of therapy, and that's what makes it so difficult to work with them. Take the returning veterans. Half of them with PTSD never go to a therapist at all, either through the Veterans Administration or on their own.
Mm.
Never, for one reason or another.
Mm-hmm.
The half that do go, half of them drop out after 1 or 2 sessions. Doesn't speak much for the type of treatment they're getting.
Yeah.
Now, the rest of them, only half of them go to therapists who've been trained to treat PTSD. What do the other half do? They go to some religious cult that says you have to pray your way out of this, or they go to a very punitive therapist who says you've just got to stick it out and endure the pain. All these nonsensical therapies, which are not what we call evidence-based, that don't have data behind them supporting them.
Mm-hmm.
So a minority of people, of veterans who are survivors of PTSD, only a minority of them are getting good and adequate therapy, I hate to tell you.
Well, you used a wonderful term there, evidence-based.
Yes.
And that, I guess, is really the most important trend today in psychotherapy.
Yes, yes.
And it's to really carefully research what modalities work, how well they work, and what precise aspect of each modality is responsible for the efficacy.
Yes, that's right. I specialize, of course, in PTSD nightmares, because sleep disorders and dreams, nightmares, yes, that is in my area of competence.
Mm-hmm.
And there are some very good treatments for PTSD nightmare therapy. I hate to tell you this, but a lot of therapies simply ignore nightmares. They think those will clear up on their own. No, they don't, because nightmares are processed differently than ordinary nightmares, than ordinary dreams. Different parts of the brain are involved in the PTSD nightmares. They require what's often called imagery rehearsal therapy, where the person and the therapist talk over how the nightmare can be changed so that it can be processed as, like ordinary nightmares, with symbolism, with metaphors.
Mm-hmm.
That PTSD nightmare is usually a replay of the trauma over and over again, the same buddy getting killed, the same child being accidentally shot to death, and the same helicopter being blown to pieces before their eyes.
Mm-hmm.
Okay, you can't redo the past, but you can put a different meaning on it. So many soldiers are guilt-ridden. Oh, I killed that child by accident. I'll never get over it. What can I do? You put a different spin on it. Yes, a part of me died too along with that child. I didn't kill that child. The war is to blame. there are casualties of war, and this is part of the horrors of war. And I will do something concrete in that child's name. I will volunteer to work in a center for abused children, do something concrete in the memory of that child. All right, now this is my preferred way of working with nightmares, where a new ending or a new meaning is put into the nightmare. A person rehearses that during the day over and over again, often drawing it, writing about it, acting it out. And eventually that nightmare is going to change to the point where it becomes more symbolic, more metaphorical, and then it can be worked through the system like ordinary nightmares, because downloading emotion is one of the main functions of dreams and nightmares.
Well, you also indicated that the brain is affected by these traumas.
I hate to tell you this, but no surprise to you, of course, but a traumatized person also has an injury to the brain. The limbic system, the hippocampus, the amygdala, are working overtime. They're overactive. And the prefrontal cortex, which makes stories out of dreams, is usually not connected to the amygdala and the hippocampus. And we've got to make that connection so that the emotion be turned into a story that can be worked with. Yeah, brains of PTSD people, not only veterans, other PTSD survivors, you can tell that their brains are different. And my saying when I talk about the topic is, for therapy, you have to change the brain, you have to change the belief system, and you also have to change the body, the way that the body reacts. And there's a fourth one, you have to change the behavior. To get the person who withdraws from society, you have to get them to establish bonds again with people, bonding and relationships. Work is often impaired. You have to get them into some sort of meaningful occupation. So behavior is a very important part of all of this. And of course, the body is changed as well as the brain, because we have as many neurotransmitters in the heart and the gut as we do in the brain. So trauma is a whole body reaction. It doesn't only involve the brain. So it's a challenge. It's a challenge for psychotherapists.
Well, and you're suggesting a very comprehensive, holistic approach.
Yes.
Which probably very few people are going to have the opportunity to, unless they really pursue it. Because most therapists are specialists rather than holistic therapists. And if you're going to go and have body work, and you're going to have talk therapy, and you're going to have occupational therapy, you're going to need a whole team.
You really do. You really do. And I've made two very small contributions to the study of PTSD. First of all, I discriminate between event and experience. I don't think there's any such thing as a traumatic event. You hear that word in the literature over and over. An event is what it is. A child blowing up in front of your face, that's an event. But the experience of watching the child being blown up, that's the experience. I mean, some people could see a child being blown up, take it in stride, yeah, that's war, it's a bad thing, go on with their work. Other people who are a little more sensitive, a little more empathic, see that child blowing, oh, what a terrible thing, I'll never get over this, I feel guilt that I was part of this, etc., 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 and they become traumatized. So there's a traumatic experience. You might say there's a traumatizing event, an event that produces the traumatic experience. But no two people will react the same to an event that is absolutely horrendous and horrific. The other contribution that I've made, one of my students, Rick Sword, was working with veterans on the island of Maui. And he read a book by another friend of mine, Philip Zimbardo, former president of the American Psychological Association, his book about time. And he thought, I can apply this to veterans. They need to discriminate between past, present, and future time. And they're caught in negative past time and negative positive time and a dismal future. So, in his work with veterans, he, using existential approaches, cognitive behavioral humanistic approaches, the whole ball of wax, got them, whenever they had an unpleasant time warp on something negative, to replace that in their memory with something positive. A positive experience with the buddy who got blown up. A positive experience that they had with buddies in the Army. Mm-hmm. And the same thing with people who were traumatized through other experiences.
I mean, it could have been an automobile accident or a crime.
Oh, good heavens. Automobile accident for sure. One of my first experiences was when I was at a summer camp for children, and one of the young campers arrived. He had survived an automobile accident. His parents were in the hospital, and we all, he will not want to go to camp. He will want to be with his parents. And he said, well, my parents are going to survive, and they said I should come and enjoy myself at camp, and so I will. Mm-hmm. So he took a potentially traumatizing experience and changed it into something positive, had a good time at camp. His parents survived. They came and picked him up. They were very happy that he went to camp. And that clued me, different people react differently to what could be an absolutely horrendous event that would scar them for the rest of their lives.
This seems to touch on the notion of self-talk. The things we tell ourselves mediates quite a bit how we are going to respond to an event.
Absolutely. This is what my colleagues and I call a personal myth. The story that we make up to explain things that happen in our lives. The personal myth that we attribute to the potentially traumatizing event determines whether or not we're going to have a traumatic experience. Mm-hmm. You're absolutely right. And so this is where meaning comes into the picture, and this is where existentialism comes in, the meaning that this has for our daily existence. Absolutely.
Some people are probably more prone, because of their own personal myth, to conceive of themselves as a victim.
Of course. I think that there are predisposing factors for PTSD. By predisposing, I think there's genetic factors. Some people have very thin boundaries, very thin psychological boundaries. Mm-hmm. Some people have very thick boundaries. There are advantages to either, of course. Okay, then comes the activating element, the potentially traumatizing event. And that event bounces off the people with thick boundaries, but it breaks through to the people with thin boundaries. Mm-hmm. Then we have the maintaining aspect, the people who have the nightmare over and over again. This maintains the trauma. Mm-hmm. Or the people who are re-traumatized by other accidents, other bullyings, other abuses. Mm-hmm. This maintains the trauma. So there's predisposing, there's activating, and there's maintaining. Mm-hmm. So anyway, back to Rick Sword's model. It's very holistic, and he adds something that none of the other therapies do. The transpersonal future. Mm-hmm. What happens when we die, and what happens to our legacy. Mm-hmm. The transpersonal future can be a heaven and afterlife. It can be the legacy that we leave to our children or the people who come after us. And so looking into the transpersonal future can also be very optimistic. Mm. So when Zimbardo came into the picture, he developed a scale that is given to all of the patients of Rick Sword and his colleagues.
Yes.
And
in relationship to time.
That's in relationship to time, shifting from a negative past to a positive past, mm-hmm. a negative present to a positive present, a dismal future to the optimistic future, and also an optimistic transpersonal future. Mm-hmm. So that package was so successful within the 2-year follow-up study, no suicides, no divorces of the men who were in that individual group. And now that's being played out in other parts of the country. Mm-hmm. But I think it's certainly one of the best therapies for PTSD, and I think it can be applied to survivors of other types of trauma as well.
Mm-hmm. You know, as we've been speaking, I'm thinking of my own background. You mentioned your cousin in World War II. Growing up Jewish, I experienced many people in my childhood who had lost family members as a result of the concentration camps. And it is as if something happened culturally to the whole Jewish people, to be honest,
Yes.
as a result of those terrible losses that occurred during the Holocaust.
Yes.
And one of the symptoms I see of that is that young Jewish people of my generation, and frankly including myself, for good reasons I think, but also for unconscious reasons I've come to discover, have been turning away from the religion. More than in any other generation, probably in the last 2,000 years, young Jewish people are abandoning the religion, which I mean, there are many complex things you can say about that, but I have to think that part of it is a response to a terrible trauma that took place before we were even born.
Oh, yes. This is very sad because, as you know, there are various approaches, various perspectives to Judaism. One doesn't have to be a fervent believer to be Jewish. One can get great meaning out of observing the Passover, for example, which I participated in a Seder during Passover. I'm not Jewish, but I'm very sympathetic to rituals and to ceremonies and spiritual observances.
Yep.
And there are other ways that somebody can participate in that legacy, and I think it's a shame that people are turning away from that legacy, or any legacy that connects one with one's ancestors. There is such an interesting thing about Holocaust survivors, as you might know, in that their children often have the same symptoms that their parents, to a lesser degree, but the same symptoms.
Yep.
It used to be thought that they simply were responding to what their parents had told them, but the parents told them very little. And there is a wild theory in epigenetic gene expression that they've actually inherited some aspect of that trauma, because trauma changes the body. Who knows? It might change genetic material. This is one of the hot controversial topics because now grandchildren are showing up with some of these symptoms.
I know it brings up the very controversial field of Lamarckian genetics, and that could be a wonderful topic for another conversation I hope we can have, but we're out of time for now, Stan. Thank you so much for being with me.
It's a pleasure.
And thank you for being with us.
Thank you.